Good morning, everyone, and thank you for being here today. My name is Dr. Asim Haseen, and I'm pleased to welcome you to this session on toxicology emergencies. Today, we'll be focusing on Tca overdose, an important topic in emergency medicine. Over the course of this presentation, we'll cover the key aspects of recognizing, managing, and treating Tca overdoses. So, let's get started and explore this critical subject together. Let's take a closer look at this case. We have a 29-year-old woman who is brought in unconscious following an overdose. Her blood pressure is quite low at 85/50, and her heart rate is elevated at 140 beats per minute. Her temperature is slightly increased at 38.5 degrees Celsius. Now, the ECG shows a QRS duration of 150 milliseconds, which is quite prolonged, and there's a terminal R wave in lead AVR. These findings are significant because they point us towards certain toxicities. Specifically, a widened QRS complex and a terminal R wave in AVR are classic signs of tricyclic antidepressant overdose. Understanding these ECG changes is crucial, as they help us differentiate between various poisonings. For example, opioid toxicity typically presents with respiratory depression and pinpoint pupils, not QRS prolongation. Serotonin syndrome involves neuromuscular hyperactivity and hyperthermia, but doesn't usually cause significant ECG changes like this. So, considering her presentation and these ECG findings, the most likely diagnosis here is a tricyclic antidepressant overdose. Recognizing these signs early can be life-saving, guiding us toward appropriate management strategies. Let's take a look at the correct answer, which is E now. When we talk about Tca overdose, there are several key features to watch for. First, you'll see anticholinergic symptoms, which include dry mouth, blurred vision, urinary retention, and altered mental status. These are classic signs of Tca toxicity. In addition, patients often present with hypotension, so blood pressure drops, which can be dangerous and require prompt management. Seizures are also common in Tca overdose, so it's important to monitor for neurological symptoms. Another important aspect is the ECG changes. Specifically, we see a widened QRS complex, which indicates conduction delay in the heart. And notably, a terminal R wave in AVR is characteristic, often signaling a significant overdose and potential for arrhythmias. All these features together help us recognize Tca overdose quickly and understand its serious effects on both the nervous system and the cardiovascular system. Recognizing these signs is crucial in guiding effective treatment. All right, let's look at this scenario. We have a patient who initially received treatment, but now they've developed ventricular arrhythmia along with worsening hypotension. The question is, what is the most appropriate immediate treatment in this situation? Now, among the options, IV magnesium sulfate, IV naloxone, IV sodium bicarbonate, activated charcoal, and amiodarone infusion. Each has its specific use. But in this case, with ventricular arrhythmia and worsening blood pressure, magnesium sulfate is often used for certain arrhythmias, especially torsades de pointe or hypomagnesemia-related issues. However, when we see ventricular arrhythmias that are potentially drug-induced or linked to severe toxicity, sodium bicarbonate can be particularly effective, especially if there's a suspected sodium channel blocker overdose. It helps to stabilize the cardiac membrane and counteract the toxic effects. It's crucial to recognize that in the context of worsening hypotension and ventricular arrhythmia, the immediate priority is to stabilize the cardiac rhythm and blood pressure. While magnesium sulfate is valuable in some arrhythmias, sodium bicarbonate is generally considered the most appropriate immediate intervention here. So, in summary, understanding the underlying toxicology and clinical context guides us toward the right choice, namely, IV sodium bicarbonate, to quickly improve the patient's condition. All right, let's look at this question. The correct answer here is C, which is marked with a check. Now, the key point to understand is that sodium bicarbonate is the treatment of choice in cases of Tca overdose when there's sodium channel blockade. This blockade can cause serious issues, including widening of the QRS complex and acidosis. Sodium bicarbonate works by helping to reverse the sodium channel blockade, which in turn narrows the QRS complex and corrects the acidosis. This is crucial because narrowing the QRS reduces the risk of arrhythmias and other complications. So, in the context of TCA poisoning, administering sodium bicarbonate addresses both the electrical instability and the metabolic disturbance. Remember, this approach is central to managing these cases effectively and preventing more severe cardiac issues. All right, let's look at this scenario. We've got a patient who has overdosed on a TCA, and now they're experiencing generalized tonic-clonic seizures. The key question here is, what is the best first-line anticonvulsant to manage this situation? When choosing an anticonvulsant in an emergency like this, we need to consider both the efficacy and safety profile. Among the options listed, phenytoin, diazepam, sodium valproate, phenobarbital, and propofol each has its own advantages and limitations. In this acute setting, diazepam is often the preferred initial choice because it acts quickly to control seizures and has a well-established safety profile in emergency situations. It's fast-acting and effective for generalized seizures. Other options like phenytoin or valproate are valuable for long-term management, but may not be the first choice in an emergency due to their slower onset or specific side effect profiles. Propofol is generally reserved for refractory seizures or anesthesia induction, not first-line treatment. So, in the context of a TCA overdose with seizures, the most appropriate first-line anticonvulsant would be diazepam. It provides rapid seizure control, which is crucial for patient stability and preventing further complications. This highlights the importance of understanding the pharmacological profiles of these drugs and selecting the best agent based on the clinical scenario. Let's look at the correct answer here, which is B. Benzodiazepines are actually the first-line treatment for seizures caused by tricyclic antidepressant, or TCA, overdose. They work quickly to control seizure activity. On the other hand, phenytoin is contraindicated in this scenario because it can actually make things worse. Phenytoin blocks sodium channels, and since TCAs also block sodium channels, using phenytoin can exacerbate the sodium channel blockade, increasing the risk of further complications. So, the key takeaway is that benzodiazepines are preferred first-line agents, while phenytoin should be avoided in TCA-related seizures. This highlights the importance of choosing the right anticonvulsant based on the underlying cause. All right, let's take a closer look at this question. It asks us to identify which medication should be avoided in TCA overdose-related arrhythmias. As we know, tricyclic antidepressant overdoses can cause serious cardiac issues, including arrhythmias. So the options are sodium bicarbonate, lidocaine, magnesium sulfate, amiodarone, and benzodiazepines. Now, sodium bicarbonate is actually the classic treatment for TCA-induced cardiotoxicity because it helps stabilize the cardiac membrane and reverse the sodium channel blockade. Lidocaine and magnesium sulfate are also used in certain arrhythmias, although magnesium can be particularly helpful if there's a magnesium deficiency or torsades. Amiodarone, while a potent antiarrhythmic, is generally avoided in TCA overdose because it can worsen conduction disturbances. But the key point here is benzodiazepines. They are primarily used for seizures or agitation, not for arrhythmias. Moreover, benzodiazepines don't have a direct negative impact on cardiac conduction. Therefore, the medication we should avoid in TCA overdose-related arrhythmias is amiodarone. It's important to remember this because using certain antiarrhythmics can sometimes exacerbate the problem instead of helping. So, the correct answer is D, amiodarone. Correct answer is D now. Let's discuss why that is. Class IA, IC, and III antiarrhythmics, like amiodarone, are powerful drugs used to treat arrhythmias, but they also have some important risks. Specifically, these classes tend to worsen sodium channel blockade. And, as a result, they can actually increase mortality in certain patient populations. So, understanding this is crucial because it highlights that not all antiarrhythmic drugs are universally safe. In fact, some, especially the ones in these classes, can be harmful if not used carefully. This underscores the importance of selecting the right medication for the right patient, considering these potential risks. This point ties back to our overall theme of safe and effective arrhythmia management. Now, let's look at this question about what finding would require ICU admission after a Tca overdose. The options are sinus tachycardia, mild confusion, a QRS duration of 100 milliseconds or more, isolated anticholinergic signs, or a normal ECG after 2 hours. The key point here is that we need to identify the most critical indicator of severe toxicity that demands intensive monitoring and possibly aggressive intervention. Among these options, a QRS duration of 100 milliseconds or more stands out as the most concerning. This finding indicates significant cardiac conduction delay, which can lead to life-threatening arrhythmias. While sinus tachycardia and mild confusion might be present, they are less specific or less immediately dangerous compared to a widened QRS complex. Isolated anticholinergic signs, like dry mouth or blurred vision, are typically less severe and don't usually require ICU care unless accompanied by other critical signs. And if the ECG normalizes after 2 hours, that suggests the patient is stabilizing, and ICU care might no longer be necessary. So, in summary, the finding that mandates ICU admission in this context is a widened QRS complex, specifically greater or equal to 100 ms, because it signals a high risk for serious cardiac complications. The correct answer here is C, as indicated by the check mark. Now, let's talk about why that's the right choice. When the QRS complex duration is 100 milliseconds or greater, it's a significant warning sign. This prolonged QRS interval can actually predict the likelihood of seizures and ventricular arrhythmias. And that's a crucial point because these conditions can be quite serious. So, if we observe a QRS duration of 100 milliseconds or more, it's essential to take action. It means that the patient requires intensive care monitoring to promptly identify and manage potential complications. This detail underscores the importance of closely watching the QRS interval as part of our overall assessment and management strategy for these patients. It's a key piece of information that helps us prevent adverse events and ensure patient safety. Let's take a closer look at the pathophysiology behind Tca overdose. First, one of the key effects is sodium channel blockade. This impacts cardiac conduction and can lead to arrhythmias, which are a major concern. Next, we see anticholinergic effects, which explain symptoms like dry mouth, blurred vision, and urinary retention. They result from the drug's interference with the parasympathetic nervous system. Another critical point is GABA inhibition. Since GABA is the brain's primary inhibitory neurotransmitter, its inhibition can lead to seizures, which are a serious complication in overdose cases. Moving on, alpha blockade causes vasodilation, leading to hypotension or low blood pressure, which we need to manage carefully. Overall, understanding these mechanisms helps us target our treatment strategies effectively in Tca overdose. Recognizing how these effects interplay is vital in managing and anticipating patient complications. Let's go over some of the key clinical features we see in Tca overdose. First, patients often present with coma, which indicates a significant level of central nervous system depression. Seizures are also common, reflecting the neurotoxic effects of these drugs at high doses. On the cardiac side, one of the hallmark features is a widened QRS complex, typically greater than 100 to 120 milliseconds. This widening signals delayed ventricular conduction, which can be a precursor to more serious arrhythmias. Speaking of arrhythmias, ventricular arrhythmias are a major concern because they can be life-threatening if not managed promptly. Patients might also experience hypotension, which results from the drug's effects on cardiac contractility and vasodilation, leading to decreased blood pressure. Additionally, hyperthermia can occur, often as a result of the toxic effects on the hypothalamus or due to agitation and seizures increasing metabolic demand. All these features highlight how Tca overdose affects multiple systems, especially the heart and brain, making it a critical condition that requires swift recognition and intervention. Understanding these clinical signs helps us anticipate complications and tailor our treatment strategies effectively. Let's talk about the management of ICU patients in this context. First, ABC stabilization is our top priority: airway, breathing, and circulation. Ensuring the patient has a clear airway and stable vitals is essential before proceeding with specific treatments. Next, IV sodium bicarbonate boluses are often used, and sometimes an infusion, especially in cases like Tca overdose, to help correct the metabolic disturbances and stabilize the cardiac membrane. Benzodiazepines are crucial if the patient is experiencing seizures. They help control the seizure activity and prevent further neurological compromise. Early intubation should be considered if the patient's airway is compromised or if they're unable to protect their airway, which is common in severe cases. Continuous cardiac monitoring for at least 24 hours is vital because Tca overdoses can cause arrhythmias that might develop or persist over time. Overall, the key here is a systematic approach, prioritizing stabilization, controlling seizures, and vigilant monitoring to improve patient outcomes in these critical situations. All right, now let's talk about what not to do in cases of Tca overdose. First, avoid administering phenytoin. It's not effective and can sometimes make things worse. Next, do not give amiodarone or flecainide, as these can increase toxicity or cause dangerous arrhythmias. Similarly, flumazenil is not recommended because it can precipitate seizures in Tca overdose cases. The key takeaway here is that these medications are either ineffective or potentially harmful when managing Tca overdose. Remember, understanding what not to do is just as important as knowing the correct treatments, as it helps us avoid worsening the patient's condition. Let's talk about pearls in Tca overdose management. First, ECG is actually the best predictor of toxicity. It helps us identify dangerous levels of toxicity early on. Instead of focusing solely on drug levels, which can sometimes be misleading, we should treat QRS widening. Widened QRS complexes are a clear indicator of serious toxicity and require prompt intervention. Additionally, alkalinization of the blood can be very helpful because it improves the protein binding of TCAs. This reduces the free, active drug in the system and can lessen the severity of the toxicity. So, in summary, always keep an eye on the ECG, prioritize addressing QRS widening, and consider alkalinization as a key part of treatment. These points are crucial for effectively managing Tca overdose and improving patient outcomes. Thank you so much for your attention today. I really appreciate your time and engagement throughout this presentation. We've covered a lot of ground, from the key concepts to practical applications, all aimed at helping us better understand and implement these ideas. Remember, the main takeaway is how these strategies can make a meaningful difference in our work and goals. I hope you leave here feeling inspired and equipped to take the next steps. Thanks again for being such an attentive audience.